All right, well, hello, welcome back. My name is Ben, very glad to be here. Thank you all so much. Contrary to popular belief, I do not have all the answers, so I would like to blame my colleague there, Dr. Michael Winters, for setting the bar very high. So we will talk about the gray literature, lots of mucky stuff with respect to intubation, and hopefully review some of the recommendations with respect to cardiac arrest. This is one of my favorite topics, and unfortunately, the deeper we dive into the weeds, the more we see that there may not be any definitive answers. So, thank you for being here. Very exciting. Without further ado, one little caveat. I think we should probably call this talk the intubation or the airway management of patients in cardiac arrest who are not suffering from trauma or the virus that shall not be named. So, for the purposes of this particular discussion, we're going to take a nice break and focus on the medical cardiac arrest patients. So hopefully this will be something on the horizon when everybody's feeling much better. Your bars, or not necessarily the bars, everything is open, and we'll be able to have a good time and a good discussion. All right, so here's what our objectives are. We're going to talk about some cardiac arrest, what to do in terms of turning patients over. And I'll talk about the priorities. And I know that Dr. Winters alluded to this earlier to say, well, what do we do when we get a patient in cardiac arrest? Should we just intubate them with a video laryngoscope into arrest? And as emergency physicians, how do we turn over care appropriately? So we'll talk about those three things as well. All right. So for those of you that review the literature, it is interesting to note that it's very device focused. In other words, we're always trying to find out whether it is the BVM, the endotracheal tube, or my not so favorite, the King Airway. And a lot of the trials are based upon devices. And this can be pretty problematic for our emergency physicians because really the airway management discussion is a little bit more global, meaning we want to figure out what we want to do with your bag valve mask, non-invasive versus invasive. But a lot of the studies that we talk about look at devices. So for those of you that are old enough, or mature enough, I should say, to remember that's Johnny Gage from, that's actually paramedic Johnny Gage over there from Emergency 51, when he was actually managing cardiac arrest, but I think an esophageal obturator airway, which is like the very distant cousin from the King. And unfortunately, there's all these algorithms. So we'll hope to walk you through the airway literature and come up with some recommendations to bring you right up to 2020, and perhaps just to the edge of an answer to Dr. Michael Winters' question. In terms of cardiac arrest, we have to think about several phases. And I think whenever we look at the literature, it's important to remember for medical cardiac arrest, meaning that patients that drop in front of you, we had a nice example of that. And I appreciate using Dr. Matu, where if he had a cardiac arrest while he was keeping time, what phase of the cardiac arrest would that be in? And that would be the electrical phase. Now, hopefully, if it gets a little dry, we can perhaps live stream that cardiac arrest here. Dr. Matu is saying no because we have to social distance. But in any event, if somebody drops dead from cardiac arrest immediately, that is the electrical phase. And there is nothing that actually improves outcomes other than defibrillation. So just to be very clear, if you were to look at all of the cardiac arrest literature, those patients benefit from rapid defib. Now, these patients are the cardiac phase over here. The cardiac phase is basically, that's when you need CPR to reperfuse the myocardium. And so when you're reperfusing the myocardium, you're priming it for defibrillation. And there may be a role for defibrillation, but not entirely clear. Meaning that, what do we do for intubation there? Should we give CPR first and prime the pump, then defibrillate? It's not entirely clear, but that's where we first kind of consider what we do for airway. So electrical is defibrillation first. This phase is prime the pump. And over here, in terms of the metabolic phase, what do we do in the metabolic phase of the cardiac arrest? And I think it's very clear that I don't think there's anything that's necessarily been proven. So to be very clear, if you get your cardiac arrest and it is 15 minutes out and you have exhausted all your options, you're debating IO versus IV, I think that's the time we all can say where you can experiment a little bit, meaning that there are no proven therapies. So we can relax the questions and say, is it IV versus IO? In the metabolic phase of cardiac arrest, I don't think there's not anything according to literature to prove what actually works. So no proven intervention. If you want to do an LT airway, if you want to intubate somebody, perfect. Probably all of that is fine. All right. So here's the review of the literature where we are so far. If you look, I think at all we've been doing this probably resuscitation standardized literature for about 40 years. There's really not a lot of proven benefits. And I think it's always important when we look at what to do with cardiac arrest. It should be focused on defibrillation early as possible, invasive management, really not drug therapy because it's not really clear that any of those medications do anything. The BVM constantly emerges as a very good option, meaning that if you look at all the cardiac arrest literatures, people that receive BVM are more likely to survive, more likely to have a good neurologic outcome. But we'll talk about how those biases play out. And then the acceptable airways, according to 2019 AHA, are pretty much anything, right? You can do a BVM if you get good ventilation. You can do a supraglottic airway. You can do an endotracheal tube. So if we look at all the literature up until now, most cases, all airways are acceptable. We really don't have any proven therapies, and your best chance at survival and a good neurologic outcome is basically early intervention, right? So bystander CPR and all that other stuff. So we could actually argue that if you look at the best strategy for airway management, initially it should be probably passive ventilation and hopefully arrest around a bunch of people that will do compressions for you. So, but unfortunately where we are, sometimes that is not always the case. All right, so the road down the tube, we're going to talk about a couple things. We're going to look at the PART trial, the Airways 2 trial, and then we're going to look at the ILCOR recommendations. All right. So, and after that, we'll come up with basically the latest recommendations and bring it up to speed in 2020 and provide those awesome answers. So, in 2019, this was published in JAMA. This is the PART trial, the Pragmatic Airway Resuscitation Trial, a much better title than the effective laryngeal tube on the initial survival, or the 72-hour survival of patients intubated in cardiac arrest. And what this looked at was there were 27 agencies, 27 EMS agencies around the United States, and a primary outcome of this particular trial, the primary outcome was survival after 72 hours of cardiac arrest. So these paramedics, and actually some were EMTs, they were randomized to initial trial of laryngeal tube insertion and then endotracheal intubation. And the thought was, what is actually associated with 72-hour survival, and what are the complications? It's very difficult to do randomized controlled trials out in the field, and this was somewhat landmark because it was randomized, and it actually looked at standardizing care. And for those of you that are familiar with this, they use the King Airway. Now, this is only common when you look at the recommendations as to why the King Airway was chosen. The King Airway was chosen because it was the most common in the setting of American EMS, and that's Western EMS. That's not to say it's the best airway, but a lot of EMS institutions, and I would say a lot of emergency clinicians, when you're looking at cardiac arrest, it makes sense to not interrupt compressions. And so the thought of deploying a rapid supraglottic airway is something that has appeal because you don't have to interrupt your compressions. So that's the reason. They chose it sort of a priori, and they chose it influenced by how many EMS systems were utilizing the King Airway. There were 3,000 patients in the study group, which was excellent. And a lot of these EMS agencies participated in the ROS consortium. And basically, this is kind of the study diagram, and the primary outcome was as follows. Now, all of us are also interested in the secondary outcomes, which are things like regurgitation and complications. And what this trial found, and this trial, it's interesting because if you've been looking at the cardiac arrest literature, this has been discussed multiple times, but the subtleties in this trial are very important for informing future iterations of our cardiac arrest management. So what happened with this, and this is a busy slide from the JAMA network, but it actually shows that your 72-hour survival was better if you had a laryngeal tube placed. So a lot of people said, why are we doing airways? Meaning, why are we actually doing effective airways if this is an increased time or a decreased time to ventilation? The complications are the same. Why don't we just intubate everybody? Or I'm sorry, why don't we just place the supraglottic airway in everybody? And what is really important to think about in this particular study is the first pass success of intubation in this study, 27 EMS agencies was 57%. And a lot of these EMS agencies were very high performing. And I think those of us in emergency medicine, we convinced ourselves and we love to be airway operators, but the reality is airway management in cardiac arrest is not always associated with a high success rate, meaning if you look at the prevalence of non-invasive ventilation, if you look at the strategies out there, the decreased frequency of intubation, I think it can be said that we are not intubating people with such reliable success. So remember, the results of this trial are couched against the background of a very poor initial success rate, which is almost like the flip of a coin. So I think the question is, if you're a system manager and you're involved in EMS, or if you're looking at how to operationalize a airway management strategy, you'd be really hard pressed to say that, we have to intubate. I think that's the lesson of this particular trial, meaning that we oftentimes think of endotracheal intubation as the be-all, the end-all, the touchstone, and unfortunately with all the randomized trials we look at, the controlled evidence, it's very difficult to position as ETI as an initial strategy of airway management. That is, I think, important, and it's also important to look at what device was used in the baseline low level of success. The other thing for those of us in the hospital is that the complications were also not increased, meaning that aspiration, regurgitation, all that was the same. And I think it makes sense if you're deploying the supraglottic airway, you're much easier, much more likely to get a ventilation on the first attempt. So it's faster. That is basically the PART trial. So viable first-line airway, how do I extrapolate that into practice? We'll talk about that a little bit later. Maybe we should be considering supraglottic airways, and the complication rates were similar. Now this was followed up again by our friends in England, across the pond actually, as they say, and hopefully for those of you over there, this was an excellent study. It's good to see you. They're like, that guy cannot do an English accent. This was the Airways 2 trial, and it randomized across 4 sites in England. And again, important to this particular trial is that the intubation was standardized. So there was no video laryngoscopy. So contrary to the scenario earlier, these paramedics did have intubation capability, but they did not have video. And that was purposely done to standardize the approach. They had a bougie and they had direct laryngoscopy. This was randomized to the iGel, which is a second-generation laryngoscopic device. So it said, well, what if we get these people, we randomize them, and they were randomized before. So this was not randomized to the point of arrest. So a lot of the paramedics actually had initial training in endotracheal intubation or more training in endotracheal intubation before the trial actually started. So you're looking at a very standardized practice. I would say, for example, this particular trial, it resembles more about what we do in the emergency department, meaning that the airway is very codified. It's very checklist. It's the approach is pretty clean. And what happened over here? So what is the case with the randomized trial over here? I was going to ask a question, then I realized that all of you are in the audience. So let's proceed. In this particular trial, the patients that were intubated, and the primary outcome that was different. The primary outcome was neurologic survival. Okay, neurologic survival over a discharge. This was not 24-hour survival. So we're also looking at very different primary outcomes. And the conclusion of this trial is that the patients alive with little or no disability was similar between the groups. So contrary to the previous trial, this trial said, what if you had a highly controlled system? What if you had people or providers that were not necessarily more well-trained, but more reliably trained in endotracheal intubation? What does that change the success rate at all? And the answer was no. This trial that was randomized, that was controlled, did not find any difference. And when you look at a lot of the secondary outcomes in the Airway trial, they were also similar. So what we're seeing between these two trials is the fact that whether you randomize a supraglottic airway or whether your first choice is supraglottic or whether it is an endotracheal intubation, it's very difficult to discern a difference in survival. Very difficult, especially if you look at this particular trial, which had a little bit more participation in it, right? So you had a higher enrollment, and you also had a higher baseline training of intubation, where you looked at initially if you recall in the Wang trial, the initial airway success, first pass success was about 57%. Here they were upwards of about 80% as well. So probably results more akin to what we would find in the hospital. So take-home points, this trial, a lot of people said it kind of contradicted or countermanded what was seen in the PART trial as well. Again, very different implications, I think, for EMS. So if you were in the pre-hospital setting and not managing airways in the hospital, and you want to say, well, do I have a device that I can deploy for my providers that would decrease time to ventilation, decrease insertion? I guess it makes sense that you can deploy something a little bit simpler, and you have a lot of things in that toolbox. So now we come here to the resuscitation trial, and this was actually talked about by my colleague earlier. So when ILCOR reviewed the recommendations, this was a meta-analysis of all of the controlled trials for out-of-hospital cardiac arrest, and it basically looked at outcomes in terms of survival, and it tried to come up with recommendations. It utilized a grade format. It looked very clearly at controlled and randomized stuff. It also looked at observational case series. And one of the best things about reading this trial is you can feel the author's frustration. So when I was asked, let's look at cardiac arrest and come up with some conclusions, in this particular trial, it showed there was a lack of inter-examiner reliability. There was high heterogeneity, meaning the outcomes were very different. The tools were different. So you could most of the trial is about, well, we'd love to make a recommendation, but in England, they're using the SGA. In America, they're using the King. At this place, they're using the LMA. And some places have physician teams. Some places don't do that. And they actually looked at in-hospital. So in order to look at in-hospital cardiac arrest for airway management, there was literally no data. So what we were dealing with is not necessarily a paucity of data. We were dealing with very difficult airway quality, meaning that we were comparing very different outcomes over here. And I think what we were seeing in stuff like this, and I know this is a busy slide, I will emphasize a lot of the key points here, is that the research is very difficult to guide us. We have to fall back on what we talked about earlier, which is physiology. So when you look at this meta-analysis, and I think it included about 80 different trials, 11 of which were controlled, ranging from 1984 to 2018, they really couldn't find any high-quality evidence to recommend intubation over supraglottic airway insertion. And that, I think, is extremely important. The other things I want to talk about, because this is our job, right, as emergency physicians or as resuscitationologists, practitioners, we have to synthesize the evidence and make a split decision when the patient comes in or when the patient comes into cardiac arrest. How do we synthesize the evidence? And I think when looking at the confusion, there's a lot of really good things we can distill here. One thing is, resuscitation time bias. And this was something that I was not very familiar with. But when you look at all the controlled trials, the key to resuscitation time bias is that your results are confounded by the use of the BVM, meaning if I were to put a BVM against the supraglottic airway, LMA, and I don't care if you had all of the intubation expertise of a rich left hand, for example, what would happen is that your BVM and cardiac arrest would always be associated with better outcomes, because consistently the patients that survive, right, are earlier in their course. They're more likely to receive non-invasive or bag valve mask ventilation. If you look at the PART trial, what was very interesting was that a lot of the patients there regained consciousness before they could even proceed to an advanced airway trial. So it may not be that the bag valve mask is a better device. It may just be reflecting our knowledge of what we know about cardiac arrest, meaning that if patients are more likely to survive with non-invasive management, because most of the people that you're going to get back are going to respond to defibrillation. They're going to be in that electrical or initial circulatory phase of cardiac arrest. But I found it very interesting that the experts, certainly much smarter and much more in a much more systematic approach than I would do for this lecture, when you look at it, they couldn't come up with anything other than to say, as usual, more research is needed. So I think it's very telling when we look at cardiac arrest literature, and I'm so glad it is absolutely engaging to look at it every year, which is what we owe to our patients, we owe to ourselves, that conclusions are still the same. The emphasis really has to be on a couple things, which we'll talk about when we kind of wrap up. So what do we do? What do we do with all the literature? We've got 2 randomized controlled trials that came out in 2018, published in 2019. There was another Bayesian analysis of the PART trial that came out in Annals of Emergency Medicine. How do we distill these recommendations into our daily practice in the emergency department and in the pre-hospital care? So what are some take-homes for airway management and cardiac arrest? So what we're going to do is I'm just going to take out let's figure out from the out-of-hospital all the way to the in-hospital, and hopefully I'm sure there'll be some consensus. So in the out-of-hospital setting, the best airway management strategy may be no airway management strategy, meaning that if somebody goes down, the priority is in defibrillation. The priority should be on bystander CPR, passive ventilation. And I think there's lots of good studies to suggest that even if you put a non-rebreather on somebody or just compress them in a setting of medical cardiac arrest, that's probably okay. And again, those of us that are involved, and this is certainly a public health issue, we interact with EMS agencies, and I think it's really clear that the strategy is not about the device. So initially, we're progressing from a non-invasive, passive model of airway management, especially for the bystanders or for lay rescuers or in the initial phase of cardiac arrest, because as we mentioned, right, our focus should be on defibrillation. Very clear. So now as we're moving to the professional rescuers or EMS, what do we tell our EMS colleagues? And I think it depends on the system. Now we have people from, I'm sure, all over the place. We enjoy a very broad audience, and depending upon where you function and what the capability of your providers are, we need to figure out an airway strategy that is scalable and appropriate. And this is where I think if we look at the evidence, we can suggest that the initial airway management strategy in cardiac arrest should be non-invasive, meaning that if you use a bag valve mask with minimally interrupted compressions, and you're able to bag low and slow in your traditional medical cardiac arrest, there is not a lot of evidence to suggest that you need to reflexively put down the supraglottic airway. And remember, that is another trial that has yet to be done. In other words, do we randomize people just with BVM? There's a lot of observational studies, but I think there's a lot of anecdotal evidence to suggest that. So if you are involved in an EMS system that employs paramedics, for example, and you have the ability to intubate, you have the ability to stick an advanced device down there, I still don't think there's an imperative for quote-unquote definitive airway control in the field. Whether you use a supraglottic airway, whether you use a King airway, I don't think there's a magic bullet. I think the literature would suggest as long as you can ventilate and not interrupt the quality of compressions, you should be fine. So now we translate this patient coming into the emergency department. So now they may be in a circulatory to metabolic phase of the cardiac arrest. What is the best evidence in 2020 to do? And I think there's still a little bit of practice. So what I would say is if somebody comes in and they are bagging effectively with a seal, and this is, again, your usual medical cardiac arrest, you can set up for a supraglottic airway, set up for intubation. I don't think, with all due respect, it matters, meaning that you can focus your resources on the most important things. If you wait till another person comes in the room, perfect. There is not an automatic imperative to jump to a device. And I know when we talk about the resuscitation paradigm, you have an airway manager. That airway manager initially could certainly just start with BVM and set up for a supraglottic airway. I think it is very difficult to say in 2020 that you absolutely need to put an endotracheal tube down there. So whatever works for you, whatever is available, whatever is in your toolbox, as long as we don't interrupt ventilation. So to piggyback on what Dr. Winter says, I would say it doesn't matter. If he was going to walk in there with video laryngoscopic devices and not interrupt compressions, perfect. If you were just going to deploy a King Airway, perfect as well. I think when endotracheal intubation becomes an issue is when patients are proceeding onto ECMO or when they're in the intensive care unit. Because after we are dealing with the post-cardiac arrest syndrome, which is, stay tuned, an entirely different podcast, entirely different webcast, that's where you may need to titrate a little bit more specifically. You're dealing with ARDS and other variables that may be a little bit more tightly controlled for intubation. So for our emergency department and initial resuscitation colleagues, if somebody comes in with a supraglottic airway and you've got end-tidal CO2, I think that should be fine. The imperative is as Dr. Winters and others have suggested, if you suggest airway, if airway is indicated as the primary etiology of the arrest, consider the endotracheal tube, or if you're proceeding to ECMO where you have compressions ongoing, we all know that the supraglottic airways are not very good at maintaining a very tight seal. They're also not very good at high pressure airways with asthma, so things like that. So I hope when we talk about what to do, we've gone over a couple of things in terms of some basic strategies that are predicated upon the evidence. I think these are consensus statements that emerge from a review of the literature, from the PART trial to the JAMA trial, and also up to the ILCOR review. And I think we have to also, the final thing we have to synthesize into our airway intubation or our airway management checklist is what time are they in the arrest? And sometimes, depending upon how far we are progressing in resuscitation, the emphasis of airway and the etiology of the arrest, the airway matters maybe a little bit less initially. So with that, I'd love to take some questions. I very much appreciate the opportunity to talk about the airway management, and hopefully this was a meaningful review, bringing us right up to the end of the ILCOR statement and not answering any questions definitively. Thank you.
Okay, we do have a few questions, and this one is kind of a segue to what you mentioned at the very end. What is the ideal time to intubate if a patient comes in arrest, assuming it's a primary cardiac event? ACLS doesn't really mention what the ideal time is, so what would you suggest, or would you just suggest putting a supraglottic airway in during CPR?
This is an excellent question because, to be very clear, there is not a good answer as to when intubation needs to happen. I would say if you have trouble oxygenating or if the supraglottic airway seal does not work, that's a good time to intubate. And when you intubate, make sure you've done all the other priorities. So in general, what I like to do to kind of filter into this or to kind of have a rough guideline is when you're making the decision to intubate, make sure your checklist of I'm doing minimally interrupted compressions, I have good recoil, I'm using good metrics, I have a plan, we have good access. I usually will give maybe after about 5 minutes or the initial round of compressions, then we can start thinking a little bit more definitively about airway. But I would say if there is no airway and you're doing well with a bag valve mask and you're one person, I think a supraglottic airway would be fine. What moves intubation a little bit further up in the spectrum for me personally is if you have trouble oxygenating, because remember, the literature in medical cardiac arrest, airway in terms of endotracheal intubation never becomes an imperative unless you're crashing those patients onto ECMO, traveling to a cath lab, so you have time. And if you're going to intubate, which is fine, make sure you have adequate resources so you can do it in a way that minimally interrupts compressions, and the literature would suggest anywhere from 10 to 15 seconds.
Sure. Two more. If you do put the SGA or LMA in, do you usually switch it out to a true endotracheal tube later, or?
Later, I do. Excellent question. I'm glad you mentioned that. When we talk about supraglottic airways, this is just my preference, disclaimer. I like the ones with a lumen, meaning a supraglottic airway or an LMA, because you can facilitate tube changing much easier. So I typically will do it later. And actually, when you look at these survival studies, that's what the precedent has been in the studies. The PART trial, I think 72% or 60-something% were switched out for an endotracheal tube.
Okay. And last question. Don't want to open up a Pandora's box here.
Oh, we've got COVID, Pandora.
In the COVID era, does intubation help decrease aerosolization of the virus?
So so I would say two things. Number one, probably yes. If you have a closed circuit with a viral filter, you probably are going to decrease aerosolization. The real question, which is an even deeper Pandora's box, is what should we be doing? Because the patients that are intubated in COVID, the mortality rate is very high. So if you're progressing to cardiac arrest in the setting of a COVID positive patient, the other thing we need to do is think about the outcome of that arrest, because those survival rates are pretty dismal. But the answer simply is yes, it should theoretically decrease aerosolization. Sure. Just don't forget to protect yourself.
And for all those people on live stream and YouTube, we'll be doing some further podcasts on airway management in the COVID era, and we'll definitely send that out to all of you. So,
all right, thank you for your time.
Thanks.